Welcome to DentalXP.com. I'm Dr. Maurice Salama, and in today's video we're going to be going over the treatment of a failing deciduous or over-retained deciduous canine. After many years of function, the tooth was removed and the soft tissue was allowed to heal in the area of the maxillary right canine. What we're going to attempt to do is using cone beam CT technology, understanding that we have most of the defect filled with bone. We're going to attempt to place the implant within the confines of the remaining ridge. And this is sort of reverse engineering. What you're going to see today is the fact allowing the area to heal first and then coming back and placing the implant. We're utilizing the Ritter Dental implant system. We're drilling through the soft tissue transmucosally, understanding that we have the proper angulation and enough bone to support the implant in this area. As you can see here, the implant is then placed utilizing a hand driver, and we're going to gain 40 Newton centimeters plus of initial torque insertion. This implant has a spherical design, tapered thread with micro grooves, and now we're going to hand ratchet and tighten the implant down to its final placement, approximately 3 millimeters below the future margin of the restoration or the height of the gingiva. We're now making sure that the implant is placed appropriate depth for future restoration. And immediately we are going to place a scan body. This is a dual purpose scan body which allows us to not only to scan the implant the day of surgery and send it off to the laboratory utilizing a digital file, but also allows us to utilize it as a temporary restoration as well if we so wish. We're going to go ahead and utilize the 3-shape optical scanner to scan the implant, scan the soft tissue first, then scan the implant body and the scan body, which will transfer the information to the laboratory. This gives the laboratory the opportunity to start the processing of the final permanent abutment and restoration, but can also facilitate an immediate provisional restoration within a few days' time. Here what you're seeing is the stitching of the optical images being performed chairside the day of surgery. And you can know that we're doing this because the soft tissue has not been changed or altered at the time of surgery. We went ahead and placed the implant without changing the morphology of the soft tissue, understanding that by doing that we can send the laboratory an ideal soft tissue replica. Here what you're seeing is the bite being recognized, so we have the soft tissue, the scan body which gives them the implant positioning below the soft tissue, and of course then the bite registration. Only then can we then go back to the surgical site, understanding from the cone beam CT that there would be a bone dehiscence on the labial aspect that needed to be addressed utilizing regenerative protocols. So what we attempted to do here is utilizing modern technologies is to first process the placement of the implant and indicating the location of that implant within the jaw, and only then addressing the bone regeneration that needs to be done. This is done through a sulcular approach. A vertical incision is placed behind the first bicuspid, and you can see that when we recognize and evaluate the position of the implant, you can see quite clearly that there is somewhat of a dehiscence on the labial aspect just around the microgrooves of the Ritter implant. We're going to remove any of the softer granulation tissue from the previous extraction, and we're going to graft utilizing a mixture of blood-borne bioactive materials, in this case PRGF and mineralized irradiated bone. Here is the mixture utilizing the PRGF material and the irradiated bone. This is a mixture 50-50 of cancellous and cortical bone particles. Small particle sizes 250 to 850 microns, and this happens to be Mineros from BioHorizons. We're going to place this utilizing the sticky nature of the blood-borne bioactive materials. The PRGF is plasma rich in growth factors and a BTI product. we're then going to go ahead and utilize multiple layers of fibrin as an autologous membrane that is impregnated with the growth factors that are from the patient's own blood. This is mixed with vascular endothelial growth factors, or VEGF, as well as plasma-derived and platelet-derived growth factors. Only then will we suture and close utilizing a Gore-Tex or polytetrafluoroethylene PTFE suture, 5-0, and we're going to use interrupted plain sutures. And what we're attempting to do is utilizing a healing abutment at the time of suturing. This will allow us to maintain a transmucosal connection to the body of the implant so that a temporary restoration can be facilitated within 72 hours. Remember again that the only reason we are able to do this simultaneously is a reverse engineering aspect of this protocol, which is to first address the placement of the implant, scan it and send it to the laboratory, and only then address the regenerative protocols and the regenerative aspects of this treatment. Here you can see just 3 or 4 sutures being placed, minimally invasive surgical protocol. Here's the healing abutment poking through or peeking through the soft tissues. And here you can see from an occlusal view how that looks on the day of surgery. Here's the implant in place. This is again a spiral design with very aggressive threads that gives us excellent immediate stability. And here is the temporary restoration on the final abutment approximately 3 days later. You can see only minimal swelling 3 days after surgery, and now the temporary restoration is in place, and the soft tissue is then going to be allowed to heal around this implant that was placed immediately. Here it is with the smile. You can see we don't see the soft tissue line at the maximal smile, which allows this patient to heal around the contours of the abutment and the temporary restoration before the final restoration is fabricated. I hope this gives you an idea of some of the future directions in terms of implant design, reverse engineering protocols, and the utilization of optical scanning at the time of surgery to facilitate provisionalization. And in cases where there is no incisions made, a final restoration can be fabricated with zirconium, lithium disilicate, or ceramic metal within 72 hours. Very exciting time to be involved in this type of tooth replacement dentistry. I hope it's brought you some insight on where we're headed, and I thank you for being with us tonight on Dental XP. Thank you very much.